From initial symptoms to survivorship, understanding bone cancer care is crucial for primary care providers. During this episode of Banner Health's Making the Rounds podcast, we'll be exploring the complexities of bone cancer diagnosis, treatment pathways, and the vital role of primary care providers in supporting patients across every stage of their journey. We'll cover the different types of bone cancer, the importance of multidisciplinary approach, and how primary care can bridge the gap between oncology specialists and families facing this difficult diagnosis. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in, and if you're a regular listener, welcome back. With me today is Dr. Ahmed Elabd, an orthopedic oncology specialist at Banner University Medicine and practicing at the University of Arizona Cancer Center. Dr. Elabd is also the assistant professor of orthopedics at the University of Arizona College of Medicine. He specializes in treating both pediatric and adult patients with bone cancer. Thank you, Dr. Elabd, for joining us today on Making the Rounds.
Thanks for having me today.
Well, we are excited to talk to you about this very important topic. And Dr. Elabd, can you start by introducing yourself and telling us a little bit about your background in orthopedic oncology?
I first started this journey in 2005 in Egypt when I enrolled to the medical school. 7 years in the medical school and then 4 years of orthopedic residency. I got some interest in orthopedic oncology, but it was not clear until I started doing research at Texas Children's Hospital, where they had a really good orthopedic oncology surgeon, which I used to, be with her in clinic and also in the OR, and that made me really like the challenge of the orthopedic oncology. And then after that, I went back to Egypt and I did a fellowship specialized in pediatric orthopedic oncology, which really was an eye-opener for me, to learn the humanitarian aspect of this certain subspecialty. So in this certain subspecialty, it's a lot about how these patients feels and how you can manage this feeling to be, healthy and not harmful along the treatment plan. So after that, I did another fellowship at MedStar Washington Hospital Center with Georgetown University, where I really had the chance to be trained, with the best surgeons in that specialty. After that, I have done exclusive pediatric orthopedic fellowships who also give me the chance, to look behind, the treatment of bone tumor. So for me, it's like I see the patient until their maturity. So a kid with a bone cancer, there's certain ways we treat this, but if you were extensively trained in pediatrics, that gives you wider look and better examination of the details, expecting what this patient will have after the surgery to remove the cancer along their future.
Thank you for that overview, Dr. Elabd. When it comes to bone cancer, I want to take us back to the beginning. Can you share with us some of the early signs and symptoms of bone cancer? And I'm saying bone cancer as general population. Can you share with us what is the medical terminology for bone cancer?
In pediatrics, we see the malignant bone cancer, including osteosarcoma and Ewing sarcoma. Those are mostly seen in pediatrics. And then other types of benign lesions, which is more common than the malignant tumor in pediatrics, including the bone cysts, the unicameral bone cyst, the aneurysmal bone cyst, and a lot of different diagnoses that is benign but needs sometimes surgical intervention. Like, let's take the bone cysts as an example. The bone cysts, sometimes we just wash them, sometimes we have to go and inject them, and sometimes we have to do formal surgery and clean that bone cyst and put some bone void filler, and probably sometimes fixing the bone prophylactically in terms of benign bone conditions in kids. The malignant one has definitely different approach, starts with the biopsy, and then if it shows malignancy, it's a whole multidisciplinary. So medical oncologists will start with them with neoadjuvant chemotherapy, and then we would restage them, plan for surgery afterwards, taking the tumor out, resecting the tumor, and then they continue to receive chemotherapy. Sometimes in unresectable disease, we have to reach out to radiation oncology to have the patient also get radiation. And then after they finish all their chemotherapy comes the surveillance to making sure that this tumor does not come back, which is typically at least 5 years. So first couple of years, you see them every 3 months, you do scans every month locally and for any metastatic disease, and then second couple of years can be every 6 months, and then annually, you typically follow them annually for their life to make sure that there is nothing coming back. In the adult world, it's kind of different because different kind of tumors. You see osteosarc sometimes like in 60, 70 years old, but not that common. Chondrosarcoma, which is the cartilage bone cancer, we see a lot in adults. So those also are treated, with their different way, like starting from if we need a biopsy. Sometimes if it's low grade, we just can clean the area of the tumor. Sometimes we have to do big resections for chondrosarcoma. And then the biggest part of the practice is the metastatic disease. What does that mean? That, after 40 years of age, the incidence of tumors in adults become a little bit more than compared to the primary tumor. Metastatic disease means the patient has tumor somewhere in a different organ that has sent metastatic cells of the tumor to the bone. And tumors are different how they do to the bone, but the most commonly we see is prostate cancer, breast cancer, thyroid cancer, renal cell cancer, and those behave differently. And typically every type of cancer can metastasize to the bone, but those are the most commonly seen. And based on what we can see, what's the tumor doing to the bone, what the bone doing to the tumor, we decide if we need to go in and fix that bone to prevent fracture. The other part that we see is the soft tissue tumor. Soft tissue means tumors that are arising from soft tissue, from tendon, from nerve, from muscle, mesenchymal tumors that arise from these origins. Those also, we take care of them over here. And again, those patients present differently with a mass or pain.
Okay.
So the patient will say, okay, I have this lump that has been growing and I don't know what it is. Usually first thing we do is the X-ray and see what we can see, and then an MRI to characterize that soft tissue. And based on what we can see on the MRI, sometimes we require a CT-guided biopsy, sometimes we go and remove these tumors. Again, this is a huge plus I have over here is the CT-guided biopsy that, we can do the biopsy without doing formal surgery. In different institutions that I've been through, everybody got an open biopsy, which is, to me, like more invasive if they can just interventional radiology, put a needle and give me, some tissue diagnosis. That's something we have here, which has a huge difference and a huge impact, like the way I do surgeries, the way I plan for surgeries. So also having these resources available and people, really good at what they do in interventional radiology makes my job much easier, and I'm able to do less invasive procedures for patients.
When it comes to bone cancer, what are the signs and symptoms for that, and is there screening for that?
There is no formal screening I'm aware of for bone cancer. Sometimes they do some genetic counseling if one of the family has, that cancer, and then they give them, what they think about their future of surfing, that if they're gonna have the cancer or not. I would focus more on signs and symptoms. Any pain anywhere could be a bone tumor. Anywhere in musculoskeletal system can be a bone tumor, right? I know that may look scary, but
Don't tell me that, Dr. Elabd.
let's say, a kid bumped his leg or his thigh and got an X-ray, and the X-ray looks fine, but the pain is not resolving. That's one of the other alarming signs. So if I think this patient had a trauma and then the bone looks okay, but the symptoms are not resolving, I should follow up until that, symptoms are resolved, probably getting another X-ray for follow-up, maybe an MRI, if more cross-sectional imaging to see if there is any soft tissue. So the pain is one thing that you always would look for, and just keep an eye on unresolved pain to get more investigation.
Thank you for that overview. And as you're talking about the pediatric population, if they're a teenager or in that adolescent phase where they're growing and they may have growing pains, so to say, in the legs and the knees, is that something to be aware of?
The growing pain arises because the bone grows and stretches the muscle. So there is certain areas that you can know this is some kind of growing pain, like the tibial tubercle area that sometimes have Osgood-Schlatter syndrome when they have pain. And then there are different areas that produce the growing pain. So for me, X-ray is the first thing to do. So X-ray first shows me, okay, I know this area is kind of known in adolescent to have pain, and then I'll follow them up and make sure that pain resolves even over a month, over 6 months, over 12 months. But as long as they have pain that's not, resolving over time, I will need to keep an eye on them all the time.
How quickly should a primary care physician or a pediatrician initiate a referral when they feel that something is of concern, and who's the first step in that treatment?
So let's start with the pediatrics. So you get an X-ray that you see a lesion in the bone that's abnormal, right? So any abnormal lesion in the bone probably needs to be seen by an orthopedic oncologist, right? Because and then the first is orthopedic oncologist, because some simple stuff, some bone cysts, benign tumors, very common in kids, non-ossifying fibroma, some kind of fibrous dysplasia. All of these, I can give you a list at least of 10 things that does not really need any chemotherapy, any oncology, any radiation. And then once I assess this lesion and decide what it is, sometimes I need biopsy, and then I will reach out to the medical oncologist. So I would say in pediatrics, first thing, if you see something abnormal in X-ray, it's better to refer the patient to an orthopedic oncologist. Also, if you have unresolving pain somewhere that you have been following up for a while and that's not improving, there may be something else. It's also good to have an assessment by orthopedic oncologist. It may be nothing, but just checking the box, excluding the bad stuff, right? If you have a mass, soft tissue mass, definitely needs to be seen first by an orthopedic oncologist. In the adult world, I would say the same, but because the metastatic disease is much more common in adult population, so those probably comes to me with already diagnosed history of like lung cancer, prostate cancer, and those gets referred to me from their medical oncologist.
Dr. Elabd, once a diagnosis has been confirmed, what are the typical treatment pathways for bone cancer in both children and adults?
In pediatrics, there is a lot of benign lesions that you can see on the bone that does not typically require treatment, like non-ossifying fibroma. This is just an area of the bone that has not been developed normally and usually stays there. Malignant bone tumors from bone, osteosarcoma, Ewing, and also some soft tissue. Those usually, once they're diagnosed, they typically start chemotherapy as a new adjuvant. And then that's usually 2 cycles, 10 weeks before we decide where we're gonna do the surgery. The surgery usually, include removing the tumor in block, like one piece, with any tissues that you think it's contaminated, including if you did an open biopsy. And then comes the biggest part, how to reconstruct that defect, right? We have taken like 1/3, 1/2 of the bone, how to reconstruct this defect. There is a lot of options for this. So if that tumor include one of the growth plates, we typically use we typically use like endoprothesis, like metal implants to replace that area. But if that tumor does not affect the growth plate, let's say in the middle of the femur, it does not affect the proximal part where the femur grows from and the distal part, we used to use intercalary prothesis. That can be an implant or can be an allograft. Allograft means it's a processed dead bone, like from dead body, and we match these. So we can look at like the bank that has this allograft and do a CT of our kid and see what's the perfect match for this allograft, and then bring this allograft and replacing that area that we have resected. Definitely the allograft is dead bone, does not have a lot of potential to heal, but sometimes that's the option to spare the patient growth plates so they can continue to grow. again, Stammore prosthesis is always available, which is a prosthesis that can, replace the distal femur or the proximal tibia, and it grows by itself. So we put the prosthesis in and we bring the patient every couple of weeks or month, depending on the patient, and we have non-invasive, so a whole circle of device put around the patient leg, and it emits electromagnetic field that make that motor inside that implant move, so the implant grows. So that's also one of the options for replacing or reconstructing the the area that we have resected that was involved in that bone tumor. In the adults, we don't have the growing problem. So you can replace the bone, you can resect that area, you can clean like if it's a low-grade chondrosarcoma, you can just curette this tumor and fix the bone so it doesn't break. But one thing is out that I'm not really worried about growing, right? Mm-hmm. So it's kind of different. Soft tissue tumors in adults, basically, they are assessed on the MRI if they're really big, and I think I cannot get a negative margin in resection. I send them for radiation therapy, and then I go back and take them out. So mostly of the soft tissue tumors after biopsy, if they confirm it malignant, it's a resection. Sometimes plus or minus radiation therapy. And if they're metastatic, sometimes they get chemotherapy based on what kind of tumor.
Dr. Elabd, as an orthopedic oncologist, do you have any final thoughts or advice for primary care physicians that have a patient that may be undergoing or they may have a suspicion of bone cancer?
That's a really great question. And the golden answer for this question is just reach out to me. If you have a patient that you see the X-ray and you're suspecting something, or the X-ray report says that there is suspicion of bone lesion, it's completely okay to just reach out to me, send me a message, email me saying, what do you think about this? And then I can help guiding you how to deal with this patient. If I see something really aggressive, I will tell you, send this patient, I can see them tomorrow. I can prioritize which patient to be seen as soon as possible. Or so this looks like a non-ossifying fibroma. You can just follow this patient regularly with an X-ray, and if the patient started having pain, send them to me. So I can help providing when to worry, when to be concerned, when the patient needs the referral. Is just the communication. Reach out to me, ask me a question, and I'm happy to help in any way.
So important, Dr. Elabd. And we can't thank you enough for you sharing your valuable insights here today and what you bring here to Southern Arizona and all of our patients here at Banner University Medicine and the University of Arizona Cancer Center.
Thank you so much for having me, and I hope that was helpful for the audience.
Absolutely.
And I'm always here to help.
Well, we appreciate that. Thank you so much, Dr. Elabd. Thank you for joining us today, and if you found this conversation as informative as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about Dr. Elabd and the oncology services provided at the University of Arizona Cancer Center and Banner University Medicine Tucson, please visit cancercenter.arizona.edu. Thank you for listening, and we'll see you next time on Making the Rounds.